Welcome back to the Deep Dive. Today, we're getting into what is, well, probably the most demanding area of clinical practice, both emotionally and ethically.
Treatment and care towards the end of life.
Exactly. Our mission here is to take that really dense UK GMC guidance and, turn it into high-yield, actionable knowledge, something that's tailored for you, whether you're facing exams or a real-world dilemma.
And this is a deep dive where process is, well, it's paramount. We're dealing with the legal, the ethical, and the clinical obligations when life-sustaining treatment is on the table.
All governed by the Mental Capacity Act and the Human Rights Act.
Precisely. And remember, the GMC defines approaching the end of life really broadly. It applies if a patient is likely to die within the next 12 months.
So this isn't just about the final hours.
Not at all. It covers advanced diseases, frailty, acute catastrophic events. It's a very wide scope.
Okay, let's unpack this straight away with a dilemma, one that really gets to the heart of the tension here.
Let's do it.
Picture this. You're the junior doctor on call. You have a patient with advanced liver failure, expected to die within weeks, who has just lost capacity.
Okay.
Now, their family is there, and they are vehemently demanding you start clinically assisted nutrition and hydration, CANH. This is, even though your consultant has clearly documented that it would be burdensome and completely futile at this stage.
A classic high-pressure situation.
So what is your immediate professional duty, and what's the very next step you must take?
That scenario just throws you straight into the conflict zone, doesn't it? The core truth, the one-sentence takeaway that has to guide you is this. You must start with the presumption in favor of prolonging life.
But that's not the end of the story.
No. Your ultimate ethical duty is to determine the overall benefit for that individual patient, respecting their capacity and any advance wishes above absolutely everything else.
We're using overall benefit here. That's the GMC's term. But this is where the terminology can sometimes, trip people up, especially when you bring the law into it.
It really can. If you're practicing in England, Wales, or Northern Ireland, the actual legal term is best interests from the Mental Capacity Act.
I see.
So think of the GMC's term, overall benefit, as the professional standard. It's the umbrella term that describes the process you must follow to arrive at that legally required best interests assessment. It's all about the individual, not the team, not the family's comfort.
So why does this area, end-of-life care, generate so many of these really tough exam questions?
I think it's because it boils down to making decisions that inherently involve distress. We're talking about withholding or withdrawing treatments that could prolong life, even for a short time.
Things like antibiotics, ventilation, CANH.
Exactly. The SJT tests your ability to stick to a process that manages that ethical complexity. And the GMC is, well, completely unwavering on one rule.
Which is?
Decisions about treatment must never be motivated by a desire to bring about the patient's death. That is the hard line that separates this from euthanasia or assisted suicide. The exam wants to see you follow the framework, not your emotions.
Okay, so let's look at those core GMC principles, the pillars that hold this whole framework up.
Right. There are three foundational pillars. First, the presumption of life. You have to start there. Take all reasonable steps. But, and this is so vital, there is no absolute obligation to prolong life, regardless of the consequences or the patient's own views.
And that's the tightrope, isn't it? Reconciling that duty to prolong life with the duty to avoid futile, burdensome treatment.
That's where the next two pillars come in.
Yeah.
The second is the presumption of capacity. Every adult is assumed to be capable, and you have to assess capacity for each decision right at the time it needs to be made.
And you have to actively help them participate.
Yes, you have a duty to maximize their ability to take part. Simple language, visual aids, whatever it takes. You can't just say someone lacks capacity because they're making what you think is an unwise choice.
And if capacity is lost, then we shift completely to that third pillar.
Correct. The third pillar is overall benefit. As soon as capacity is gone, every decision hinges on determining the patient's overall benefit or their best interests. This means weighing everything. Benefits, burdens, risks, and including their personal wishes, their beliefs, their values.
And always choosing the least restrictive option.
Always the least restrictive option for their future.
Let's translate this into a really practical step-by-step framework. So we're back at the bedside with that patient, and the family is demanding CANH. What is step one?
Step one is always the foundation. Determine capacity. Can they meet those 4 criteria? Can they understand, retain, use, or weigh, and then communicate the decision?
And if capacity is maintained, if they can do all that.
Then for that decision, yes, that's kind of the end of the line. Step 2, autonomy is supreme. You respect their choice, whether it's to accept or refuse treatment. You document everything, of course.
What if they ask for something that's clinically inappropriate, like the CANH in our scenario?
You explore their reasons, you have that conversation, but ultimately you are not professionally or legally obliged to provide non-beneficial care.
Okay, now, if capacity is lacking, we move into a different phase.
Yes. Step 3 is consultation and legal checks. This is a critical legal requirement. You must check for two things. First, is there a legally binding advance refusal of treatment, an RT?
And second,
Is there a valid legal proxy, someone with welfare power of attorney, for instance? If either of those exists, they will heavily influence or, in some cases, completely determine what you do next.
and if there's no binding refusal and no legal proxy, the responsibility falls back on the clinical team.
It does. That brings us to step 4. The clinician with lead responsibility determines the overall benefit, but, and this is a must, they must consult widely. That means the whole healthcare team, those close to the patient, and sometimes an IMCA.
Let's just pause on that. IMCA. For anyone revising, what is an IMCA?
An IMCA is an independent mental capacity advocate. They get involved in England and Wales when a big decision, like about serious medical treatment, needs to be made for someone who lacks capacity and has no one else, like family or friends, to speak for them.
So in an exam, if the patient is totally alone, involving an IMCA is probably the safe answer.
It's often the mandated and therefore safest action.
Right. So to help consolidate all of that, let's use a mnemonic. You mentioned one earlier that helps systematically review the patient's overall benefit.
Yes, WISH. It's a simple checklist to make sure you're covering all the bases.
Which H? Okay, what's the W?
W is for wishes. What were the patient's known wishes? Any advanced statements, their spiritual beliefs, their core values. This isn't just a tick box. This evidence must be given real weight.
Okay.
I is for interests, the patient's best clinical interests. Weighing the benefits against the burdens. Is this treatment actually helping, or is it just prolonging the dying process? S is for support. Consult with your seniors. Get a second opinion, which we'll see is mandatory for some decisions, and involve the legal proxy or an IMCA.
And finally, H.
H is for harm. Which option is least restrictive? And crucially, which option prevents the unnecessary suffering that comes from providing futile care?
I like that. The mental image is clear. You only turn to the ESH framework once you've confirmed that the patient's own voice, their autonomy, is absent because of a lack of capacity.
Exactly. So let's see how the exam uses this framework to build some common scenario patterns.
Pattern 1, the advance refusal dilemma.
Right. What's being tested here is if you know the very specific legal requirements.
So what's the best action?
If the RT is about refusing life-prolonging treatment in England or Wales, it has to be in writing, signed, and witnessed. And it needs a specific statement saying the patient knew it would apply even if their life was at stake. If it meets all that, it's legally binding. You must respect it.
And if it doesn't?
Then it's not legally binding, but it's still powerful evidence of their wishes, which you have to weigh very heavily when you're working out their overall benefit.
Okay, pattern 2, the disagreeing family. This takes us right back to our opening dilemma.
It does. The test here is understanding the boundary. The family's role is consultative, not decision-making. Unless, of course, they are the legally appointed proxy.
So the best action is to aim for consensus.
Yes, explain your clinical judgment clearly and with compassion. Document everything. If there's still a major disagreement, you must get a second opinion, maybe even legal advice. But what you do not do is give them the final say.
Right. Now for the really high-stakes one, pattern 3, withdrawing CAH. Why is this one treated with such heightened scrutiny?
Because legally, CMH is seen as life-sustaining treatment, and withdrawing it is considered a very, very serious step. So the GMC demands extra procedural safeguards.
So the test is knowing that specific safeguard.
Exactly, the best action. If you judge that continuing CNH is not of overall benefit, and the patient is not expected to die imminently, so we're not talking about the last hours or days, you must get a second opinion from a senior clinician who is not part of the immediate team.
That's a non-negotiable step.
It is. It ensures objectivity. Now, if death is imminent, the whole focus shifts to comfort and palliative care, and CNH is usually stopped without that mandated second opinion because the goal of care has fundamentally changed.
That distinction in timing is a classic exam detail.
Absolutely. Finally, pattern 4, DNA-CPR decisions. The test here is about timely and sensitive communication. The best action is to make that decision early if a cardiac arrest is a foreseeable possibility. And you must discuss it with the patient or their family, unless the discussion itself would cause serious physical or psychological harm. And the guidance is really clear. Serious harm is more than just making someone upset. It has to be a real risk of a profoundly negative clinical outcome.
And you have to be really clear what a DNA-CPR order means.
You do. It only applies to CPR. It does not mean you stop all other appropriate treatments, like good symptom control.
Okay, that leads us nicely into the traps. The answers that seem plausible but are actually wrong.
First trap. Relying on your personal views about the patient's quality of life. You have to strip away your own biases about age or disability. The decision must be based purely on that structured assessment of overall benefit.
Trap number 2. Delaying a difficult conversation, like about DNA-CPR, just because it's uncomfortable.
Delaying compromises the patient's dignity. It stops them from planning. In these situations, avoidance is never the safe option.
The third trap links back to your way as a mnemonic. Ignoring an advanced statement because it's not legally binding.
Yes. Even if it's not binding, it's crucial evidence of the patient's wishes and values. If you ignore it, you failed in your duty to consult properly.
And a big clinical one, continuing futile treatment, just because stopping it is emotionally hard for the team or the family.
That is unethical. Anxiety, yours or theirs, cannot override your clinical judgment. Continuing treatment that provides no overall benefit just prolongs suffering.
Right. Let's do a quick rapid-fire round to nail this down. If a patient with capacity refuses a necessary life-saving surgery,
You respect their refusal. Autonomy is king. You make sure they understand the risks, and you document that conversation meticulously.
if a patient without capacity is expected to die in the next few hours and a family member insists on starting 5V fluids,
You only provide treatment that serves the overall benefit. In those final hours, the focus is on comfort. Unnecessary fluids would likely be burdensome and not beneficial.
if a disagreement between the patient's legal proxy and the clinical team is unresolved,
You need to consider escalating. That might mean seeking a legal opinion or even applying to the appropriate court for an independent ruling on the patient's best interests.
last one. If the team decides a DNA-CPR is appropriate, but the patient's daughter asks you not to tell her mother because she'll be too distressed,
You explain why the conversation is so important. You emphasize that the decision has to be discussed unless it will cause proven serious harm. Being distressed isn't enough, so you would need to sensitively involve the patient.
this deep dive really boils down to 3 critical takeaways, doesn't it?
It does. First, the entire framework lives or dies on a rigorous capacity assessment. If capacity is there, you respect autonomy. If it's absent, you diligently use the overall benefit model and consult widely.
Second, the highest stakes decisions require mandated rigor. Withdrawing life-prolonging treatments, especially CNH, requires that extra scrutiny, often a mandated second opinion.
And third, prioritize advanced care planning. Having those sensitive discussions about DNA, CPR, and ARTS early on protects the patient's dignity and prevents so much conflict down the line.
I think the final word has to be that professionalism in end-of-life care is defined by your adherence to process, to consultation, and to that principle of the patient's overall benefit.
I agree. And that leaves an interesting question for you to think about. The guidance says you should refuse to provide treatment that isn't clinically appropriate. But it also says that if the benefits and burdens are finely balanced, a patient's previous request for that treatment will usually be the deciding factor if they later lose capacity.
So where do you draw that line?
Exactly. Where is the line between a firm refusal of futile care and that finely balanced judgment that swings in favor of what the patient wanted? Nailing that distinction is where the very best doctors operate.
A brilliant, provocative thought to end on. Thank you for guiding us through this essential deep dive.